Good evening, ladies and gentlemen. My name's Emanuel Nuwass. I'm from Tanzania. This is country in the East Africa. And newly graduated general surgeon. Just completed my studies in MEd program in August this year. And now I'm back to my hospital, which is Haydom Lutheran Hospital. And this is located in the northern part of Tanzania, where maybe most of you have visited for the, visiting the national parks and the game reserves there, climbing Mount Kilimanjaro. We have a lot of interesting things there. So this is my personal story, but at times I'll be sharing the challenges we experience, especially to do with the surgery in the low resource settings, mainly focusing at Haydom, but this will be a picture in most of the parts of hospitals in Tanzania. So this is the map of Tanzania. It has got about more than 21 regions. And we can see that we have Kenya being our neighbors, Rwanda, Mozambique, Malawi, and we have colleagues who have worked in those countries, and you have the same pictures when they present their topics as well. So Tanzania has got about around 46 million people in population. And our health budget is around 8.8% of the national income. And per person, the country budget is about $14 per person versus $54, which is recommended by WHO. So you can imagine how little we budget from what we have in our country. Now, in terms of the health services in the country, we have one national hospital, which is located in the business city, which is Dar es Salaam. But also we have the cancer center, and all these are located in Dar es Salaam. But we have 3 consultant hospitals. These are located in different parts of the countries. At least they have an equal distribution to attend these 46 million people. And Haydom Lutheran Hospital is among of the 10 regional referral hospitals. This is second-level regional hospitals in Tanzania. And they are promoted 4 years ago. So this is Africa. Now, what is the status of the surgeons in Tanzania? According to the statistics which were given by Medical Association of Tanzania in the 2010, there were about 72 surgeons by the year 2010. Now, out of these 72, 51 were located in Dar es Salaam, 46 in National Hospital. Can you imagine? What of the rest of the country? The Dar es Salaam have got a population of around 4 million currently. So in that year, probably was 3.5 population. What of the 40 million people? Who attends them? 30. And out of the 21 remaining, half of them will be in Bugando, which is Lake Zone, close to Lake Victoria. And half of them will be in KCMC, in the slopes of Mount Kilimanjaro. What of the rural area in Tanzania? Who are attending them? Now, what is my story till I become a surgeon? And probably that will give the picture of how many of the people in low resource setting who have become surgeons. So I'm born from the pastoralist family. You can see a picture down there. Those they look like Maasai, but these are barbaric. And these are donkeys. These are not cattle. So these are the animals who are used to fetch water, to carry maize in the times of droughts when there is no food. And these are the ones we used to go and find the food to eat in times when we don't have foods in the families. Now, when I was, I'm from pastoral family, as I said, and my family had nothing to take care. So we used to go to Haydom, carry firewood to sell for, I don't know how would I say, maybe 10 cents US dollars, to have a soap, to have a uniform, to have a pen, to go to school. But at times we have to go to dig someone's farm to get just a 1 tin of maize and have a meal for 2 or 3 days. Now, so I started in that difficult situation. When I completed my primary school, I didn't have any idea who to be. But then we used to have graduations, in our country when people are finishing their school. So on the graduation day, I was given an opportunity to present just academic part, to show how our school, the picture for our school academically. And I was to present the gastrointestinal system. And I was just a second student in the class. The first one was skipped, I was chosen. I don't know why. So this was head teacher and the chairman of the village. Then I presented. They said, okay, you have to present this. You won't choose another person. So the day came. I presented. And at the end, asking anyone having a question. But it was puzzle to them. I don't know whether I did well. I don't know. But among of the invited guests was a surgeon from Haydom Lutheran Hospital, the late Dr. Olsen, who was the famous surgeon in Haydom and did a lot of surgeries. Dr. Astat will have, I think you know him, Dr. Olsen. And so he was impressed, and he said, this boy can make a good doctor. But he didn't speak to me. So when the results come, I have passed my exam, then he called. He said, bring that boy. And he knew my background. Then he sponsored my secondary school. After I finished high school, I passed well. Then I was enrolled in the hospital scholarship to join the medical school. So that was my beginning in terms of becoming a doctor. And then I started my medical school 2001. So in the senior years, that is third year, fourth year, we had a Canadian Association of Surgeons who used to train essential surgical skills. So I managed to attend such seminars, I think 2 times, when I was fourth year medical student and when I was an intern. And that gave me a very important skills that I was confident to attend and assist in many surgeries, and I developed an interest. So then I returned back to Haydom after I finished my studies in 2008. I started working as registrar, and then in 2010 I met Dr. Botman. However, in that, when I was working as registrars, I had a culture, of course, of reading before attending any procedure. And that helped me a lot. That helped me a lot in terms of gaining skills and knowledge and doing procedure properly. However, things were not easy at Haydom because this is a general hospital where when you are on call, you have to attend, mothers who are coming in labor, with obstructed labor, whatever the indication, you have to attend them. You have the pediatric cases. You have the urological cases coming, whether trauma or, And then, of course, surgical conditions. And all this, when you are in operation, you are attending a case, and you feel like now you are going to rest, just to have at least maybe a cup of tea or a plate of rice and have a sleep, then you have 3 cases waiting you to be reviewed on reception. What do you do? And at the same time, a midwife coming from maternity ward saying there are 2 obstructed labors. You need to attend them. And they all need cesarean section. What do you do? Those are the frustrations we encounter in low-resource settings. So later on, of course, I joined my residency after all that difficult time. However, it was motivating because of the results we get, the lives we save, and of course, the quality of lives we improve for the patients who are coming to attend services at our hospital. So what is about the training, residency training in Tanzania? It's challenging. We have about 4 universities which are giving the training, but we have the COSESCA, which is also offering the residence training to train surgeons as well. So per year usually is between 2 to 5 residents being admitted in a college, 1. And this, you have to have at least 3-year experience. And if your employee has not allowed you, you have to quit your job And that means you'll be studying. If you don't have sponsorship, you have to remain in employment because you can't survive. The government gives very limited positions to be sponsored for the residency training. But however, in these universities, we have a very few consultants or surgeons who are teaching, and therefore, less supervision. Most of the time working on our own, especially in night hours. And in daytime, when it's days for clinics, these consultants are occupied with outpatient clinics or are occupied with difficult cases in other theaters. So residents working in their own time. But also the other challenge is about lacking the, learning tools accessible to either update literatures, lack of supplies and drugs, and therefore all these are giving limitation in terms of conducive environment for learning. This is just a picture which is showing the limited resource. This is container for clean water. Does it really reflect that? These are the real situations in our rural settings. Now, back in Haydom, as a surgeon, what do I do? What do we do as surgeons in Haydom? So you do the surgeries in all these spectra. General surgery cases, you attend neurosurgeries, urology, reconstructive, pediatric surgeries, and at times you do administrative activities as well. Now, in surgeries you all do, from emergency cases to elective cases, appendicitis, intestinal obstructions, you have thyroidectomies, neurosurgeries, shuntings, barholes, craniotomies from emergency, having hematoma collections, but also for the kids who are coming with spinal bifida hernias closures. So all this spectra needs our attention as general surgeon in rural setting. And this is the real picture in Haydom. And you can see some of the pictures. These are real pictures. And this is the picture of my hospital, Haydom Lutheran Hospital, which is with a capacity of 420 bed capacity. I don't know if you have, is this, sorry? It's not working, okay. Now you see the, yeah. Fine, so this is the picture of our hospital, you can see, okay? We attend about 16,000 inpatients per year. We attend about 80,000 outpatient cases, and we perform over 4,000 surgeries per year. This excludes the outreach surgeries like eye, which usually they go above 1,000 cases per year. Now, our catchment area at large is about 2.2 million people, up to 2.5. Now, how do we ensure that this hospital of 420 bed capacity runs? Actually, our hospital is donor dependent. About 52% is donor. Our budget per year, the hospital budget, is about around $5 million US per year. And the government contributes only 20%, the patient fees only 20%, and others around 8%. So you can see the challenge we are facing. How do we train our doctors in hospital? This is the capacity building in a hospital. So we usually have on-job training by visiting doctors, being specialists or being experienced GPs. We have the AMREF visiting doctors who are performing monthly visits in different specialties. We have the workshops. Tanzania Surgical Associations, they do annual meetings. COSESCA as well, they do send some visitors. But we have the doctors from Netherlands as well who are coming to visit us. Matthias was there working with us, and other doctors as well, like Dr. Winter, staying there. Those are among of the examples. But we have neurosurgeons who have been visiting our hospital for 3 to 6 months, staying there, teaching. But we have as well the people who are coming for 2 days, and they want to do surgeries and leave the next day. You can imagine how busy it is. But of course, we send our doctors for, official specialization in consultant hospitals, exchange programs with like-minded institutions like KCMC and other foreign institutions. This is rural, how it looked like, and this is Haydom. So challenges, what are the challenges which we face as a Haydom, but of course as well as Tanzania? Shortage of qualified manpower or skilled staff is a challenge. Shortage of supplies and diagnostic facilities. Not only shortage, but at times, even if being available, being out of stock, or no electricity to ensure that it runs, or no qualified staff to run those diagnostic facilities if available as well. But being a private hospital and donor dependent, we have the staff turnover moving to the government, going to greener postures as well, to a well-paying institutions, and being a rural area, so most are moving to urban areas where they can have better pay in terms of private practice as well. Demotivation setting in, and we have organizational issues. So we have the foreign doctors who are coming, visiting us for a short while, coming to volunteer for some time. Well, I think they have a role to inspire the, local practitioners to ensure that despite of the challenges they face, they can offer what they can manage. So they need to be inspired even if they are working in a very challenging situation. The other aspect is they need to teach relevant knowledge and skills, which is proportional to available resources in that center, so that they can apply and help those patients who need help. We have the visitors who come, of course, and they teach big things which there is no resource to accommodate such knowledge. But then when you leave, no one is going to apply that. There is no resource to be used in that. Therefore, there is need to harmonize the required knowledge and skills during our visits. Need to do a supportive supervision. And of course, when we are transferring technology or instruments, those should be really maintainable and sustainable in such locations so that they can be really useful in long term. Of course, we need to enhance the collaboration so that we can have the required knowledge and skills and technology so that we can improve the services in those areas. So our partners who are visiting us in those low resource areas, they don't only do good, at times there are challenges as well. There are cultural differences. Cultural differences. People come and they want things to happen in the same day, in the same week. We have to appreciate the cultural differences. Slow but sure. Okay? Here is quick but sure. We have to appreciate that. Of course, we need to come into that stage, but it's a process. It's not a night thing to happen. So we need to accommodate the cultural differences if we want to transfer the knowledge and the skills to enhance the services in these low resource settings. Too much demand, it's another issue. Too short time. Well, we don't say don't come even if you have short time, but you need to appreciate how much are you going to impact in whatever you want to impact. Of course, all this might lead to easy frustration and feel like these people don't need my service, don't need my assistance, they don't appreciate what I have brought. But we have to appreciate all the challenges we face in terms of resource, cultural differences, the backgrounds in terms of trainings, all those has to be put in place so that we ensure the transfer of the knowledge and the skills and ensure the projects we want to implement really brings the change and change the lives of people. So what is my role? Just to end up my presentation, what is my role? This is my question, and this is your question. So at me is that I need to inspire, and I have been inspiring my young doctors, my young colleagues at my hospital. So even before I left for my training, I trained others to do what I've been doing. So I didn't leave any vacancy. So even if you visit such hospitals or such centers, ensure that you leave somebody doing what you have been doing. Train them to be the trainers for others. Don't leave them to know what you have impacted to them and just living with that. Ensure that they are able to transfer to the next person. And that next person should be able to transfer to another person as well. So we create a cycle of transferring the knowledge and the skills. But the lives we save and the quality of life, we improve to our patients. This should be our motivation. This should be our motivation. And of course, to advocate for the public-private partnership, especially for the donor-dependent institutions, so that the governments comes in, to support this institution so that they don't fall apart, but as well to ensure that the quality is observed for these both parties. Otherwise, I will say thank you very much for listening. Welcome to Haydom. Karibu Haydom.